read up, let me tell you about the body and some physical facts. Physical activity defined as bodily movement. You know it beneficial to every student. Chin up, push up, jogging, sit up, feeling lazy, better get up. Physical activity help your mood and memory, make you remember anything, cause it boosts dopamine and serotonin. Target attention, focus, regulate moods. Come learn something. Yeah man, listen young youth. Physical activity, healthier weight, go and exercise, students hold the faith. The more you do, the more calorie your body use. Calorie deficit, calorie get reduced. Exercise build your bone and make it more dense. A facts we attack, ladies and gents. Physical activity is of the essence, needed like full stop in any sentence. Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Physical activity.
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
One, two, three, two more. 1, 2. Adults to 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Make sure you know your health status. Go a doctor and get a regular checkup. Chronic, if we just eat right and get moving. Jumping, running, dancing or skipping. Change the children, them lazy habit. Make them play out the door and put down the tablet. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. I love me. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up.
Love your body, treat your body right. Love your body, treat your body right.
The Ministry of Health and Wellness is celebrating Caribbean Wellness Day 2023 with a weekend of wellness. Saturday, September 9. All roads lead to the University of Technology Jamaica for a sweat fest. 4 p.m. to 8 p.m. Join the 3K Fun Run Walk. Pass through the obstacle course and work up a sweat with the Sweet Energy Fitness team. Admission free. No sign-up required. Lots of prizes and surprises along with free food samples. Come, get it Jamaica Moves shirt. It's a weekend of wellness. Wow, with the Ministry of Health and Wellness.
This is the Aedes aegypti mosquito that spreads the Zika, chikungunya, and dengue viruses. Protect yourself from the bite of this mosquito.
A message from the Ministry of Health and Wellness.
This is the Aedes aegypti mosquito that spreads the Zika, chikungunya, and dengue viruses. Search for its breeding sites and destroy them.
A message from the Ministry of Health and Wellness.
Good ganja sense, learn more your ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis. Knowledge is power, youths we need that. Ganja smoking and no pitney thing that. Commercial ganja you farm then you reap. Entrepreneurs and scientists see. Good ganja sense, learn more the ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis. Be smart with your ganja, go get a permit. Ganja full of uses, make sure you learn it. Can sell eye drops, it make for eyes. Ganja can boost lives. Good ganja sense, good ganja sense. Learn more the ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis.
Brought to you by the National Council on Drug Abuse, an agency of the Ministry of Health and Wellness.
We got to be careful when using pesticides.
Alright, Richie. Can you out to mash up some spraying idea?
Yeah, I go spray them corn there.
So, are the tree wearing the protective gear?
Boy, the sun too hot for suit up here, man.
So you did read the label before you start? Wear protective gears. Your goggles, your respirator, your gloves, and a coverall. At least you did have on a cap. Mix only what you need for the day.
Good afternoon, everyone, and welcome to Scientific Session 5. I'm Ardeen Harris, and I'll be leading you through this session. We'll have 3 presenters, after which we'll have discussion and question and answers. The 3 presenters are Ms. Jada Smikle. She'll present on the impact of COVID-19 pandemic on the utilization of Jamaican health clinics. We'll also have Dr. Carol Lord. She'll present online. She'll present on maternal and perinatal outcomes of eclampsia and pre-eclampsia at public hospitals in the Southeast Regional Health Authority, SARA, Jamaica, a 5-year review. And then we will have Ms. Selena Lewis, who will present on association between sleep duration, hypertension, and polycystic ovarian syndrome in women from the UK Biobank, a case-control study. So I'll go ahead and introduce the presenters. First, Ms. Jada Smikle. She's a second-year medical student at the University of the West Indies. She holds a Bachelor of Science degree in biochemistry and a master's in epidemiology. Outside of her academic and research pursuits, Jada is the immediate past president and current membership director of the Leo Club of New Kingston. She's passionate about planning and participating in outreach and service projects that improve the lives of the wider community. Ms. Michael. Dr. Carol Lord, who will present online. She is currently the Program Development Officer in the Family Health Unit at the Ministry of Health and Wellness, having served the ministry and the regional health authorities in other capacities. She is in the final stages of completing her doctorate of public health. Dr. Lord has authored research papers in infectious diseases, pediatrics, and maternal health. She is a born-again believer and mother of 2 wonderful young adults who love people. She's passionate about public health, pediatrics, obstetrics, and research. And the third presenter, Ms. Selena Lewis. She's an epidemiologist and research assistant in the Epidemiology Research Unit of the Caribbean Institute for Health Research, currently assigned to the Caribbean and South America team-based strategy to control hypertension, the CATCH study. Ms. Lewis holds a bachelor's degree in basic medical sciences with specialization in anatomy, with first-class honors and a Master of Science in Epidemiology. In 2021, she received the National Scholarship for Mathematics and Science for postgraduates in honor of the Honorable Dr. Mavis Gilmore Peterson. Selena's primary aim is to lead research efforts to enhance our knowledge of polycystic ovarian syndrome. So, 3 remarkable presenters, and we'll welcome the first presenter now, Ms. Jada Smikle.
Thank you. Impact of COVID-19 pandemic on the utilization of Jamaica health clinics by Jada Smikle and Georgiana Gordon-Strawn. Conflict of interest, nothing to declare. This study was funded by the Ministry of Health and Wellness as a part of the Essential National Health Research COVID-19 Research Addenda. So for the background, the first COVID-19 outbreak began in China during December 2019. COVID-19 was declared a pandemic by the World Health Organization on March 11, 2020. However, Jamaica reported its first case on March 10, 2020. On March 18, 2020, a state of emergency was declared, and a series of disease control and prevention protocols were implemented. This research falls under the impact of COVID-19 on Health Systems Working Group, a subset of the Essential National Health Research Committee. Okay, so for our objective, to determine the impact of COVID-19 on the utilization of routine type 3 health clinics by comparing a change in clinic visits during the period January 2019 to March 2021. Originally, we looked at 6 clinics: family planning, antenatal, postnatal, child health, psychiatry, and NCD curative clinics. However, for the purpose of this presentation, we'll only focus on 3: family planning, child health, hypertension, NCD curative clinic. So for our method, we extracted patient count data from the monthly clinic summary report for the months January 2019 to March 2021 for type 3 health centers across all parishes. The time period for the study was the pre-COVID period being March 2019 to December 2019, while the COVID-19 reference period was March 2020 to December 2020. However, for the interrupted time series, we based our time period on January 1, 2019 to March 31st, 2021, with the point of interruption being the start of the pandemic in March 2020. For the data analysis, we assessed change in utilization based on patient counts. We generated contingency tables, and patient count was the response variable, and the year was the outcome variable. And we adjusted each variable by parish, age, and sex using 2011 census data. We calculated the percent change in utilization for each response variable and did statistical significant testing using Pearson chi-squares analysis. While for the inferential analysis component, we use Poisson regression, since we're using patient count data for the interrupted time series, and we assess each time series for autocorrelation, overdispersion, and seasonality. So just to give you a breakdown of the percentage change in utilization for clinics by health region, we saw that for family planning, the northeastern region reported the most change with an increase by 20.64%, while for child health, we saw a decline across all regions, with Western region having the highest decrease with negative 29.09%, while for hypertension, we saw the most change in the Northeastern region with 20.6% increase. Here's an example of a model of our Poisson regression through an interrupted time series. So as you can see, for the Northeastern region, during the pre-COVID period, for January 2019 to February 2020, there was a steady, stable patient count until the light blue line, which indicates the point of interruption at March 2020, where we saw a decline by 10% in patient visits. The dotted gray line indicates the counterfactual. This would happen if there was no pandemic. Western region, we saw similar results. However, the decline was much different, which was by 26%. For family planning, the percent change in utilization, we saw the highest change in IUCDs. Similar findings were reported in our time series when we did the national scale, and our incident rate ratio showed a 100% increase as well. So as you can see by the light blue line at the point of interruption, which is the pandemic, there was a sharp increase and then there was a decline. We also looked at the change in utilization for child health visits based on age group. For the age group 7 to 11 months, we saw a significant decline by negative 41.78, also with 24 to 35 months with 45.60, and for 36 to 60 months with negative 30.50. When we did the time series looking at the national data, we also saw a decline at the point of interruption, the light blue line. So as you can see, by the pre-COVID period, there was a steady increase in patient visits. However, during the COVID period, there was a decline, and this was estimated to be 26% by the incidence rate ratio. For hypertension control and uncontrolled, we saw a decline in controlled hypertension and an increase in controlled hypertension. However, when we did the interrupted time series, we saw that there was actually a marginal increase for both hypertension and uncontrolled hypertension at the point of the pandemic. However, it was for a short period of time because it began to decline again. Okay, so for family planning, for discussion, there was an overall increase of 5.7% in the utilization of family clinic services during the first year, 2020 of the COVID-19 pandemic compared with the reference period of March to December 2019. The substantial increase was 100% in utilization of intrauterine coil devices, IUCDs, may have been offered as an alternative to implant contraceptives. There was also a global shortage in condoms and birth control pills, so that may have contributed to the increase in IUCDs. For child health, nationally, there was a decline in patient visits for child health clinics for the COVID-19 period, possibly due to parents' fear of exposing their children. Similar findings were found in other LMICs like Mexico, Chile, and Haiti. And there was a 4% decline in children 3 to 6 months and a 42% decline in children 7 to 12 months. This is of concern because the vaccination schedule requires children to be vaccinated every 6 months at that stage for the MMR, etc. There was also a decline in DP3 vaccination coverage globally. As for hypertension, nationally, there was a marginal increase in the number of patients with hypertension attending curative clinics for the COVID-19 period. These results contrasted with LMICs such as Chile, Haiti, and Mexico that reported a decline in patient visits. And overall, there was an increase in uncontrolled hypertension patients. Okay, so strengths and limitations. So a strength of ours that we examined 27 months for the interrupted time series, so it gave us adequate time to judge the pre-COVID period as well as the COVID period. The interrupted time series were assessed for over-dispersion, seasonality time, and confounding factors. However, limitation would be we use routine service statistics, and that would include like systematic data entry and reporting errors, underreporting, and missing data. However, we did perform data quality checks. Another limitation was St. Elizabeth. That parish in particular had a lot of missing data, so we couldn't include it in the analysis. And for the curative clinics, we had to use June to December due to disease definition changes. In conclusion, the impact of the COVID-19 pandemic on the healthcare utilization on type 3 health centers was significant. Various essential services experienced a decline in patient uptake and adherence. The after effects of the pandemic on service utilization may influence the morbidity and mortality of Jamaican populations for years to come. The decline in utilization of clinic services require further research. And we're finished. Oops. All right. Do I go back up there? Do I go back up there?
All right, thank you, Ms. Michael. Our next presenter is Dr. Carol Lord. She will be online. So, Dr. Lord, can you hear us?
Yes, I am.
All right, you can go ahead and project your slides.
You're not seeing it? I'm sharing slide. I'm sharing.
Okay, we can see it now. You can go ahead.
Good afternoon, all. I want to thank the National Health Research Conference team for selecting this study, maternal and perinatal outcomes for eclampsia and preeclampsia in Stera, to be presented at this time. I want to thank my supervisor, Professor Afik McCobbins, and the other members in the specialists of the field, Dr. Reed, Dr. Grant, Dr. Michelle Harris, for assisting with this study. This is the outline of the presentation. I'm going to share some background information and the study findings. So, preeclampsia is a multisystemic, multifactorial disorder. Disease of blood pressure is greater than 140/90 on 2 occasions, taken 4 hours apart, plus proteinuria within 300 grams within milligrams of protein in a 24-hour urine, usually after 20 weeks of gestation in a previously normotensive mother. Eclampsia is convulsion in any woman during pregnancy or in the first 10 days postpartum, along with high blood pressure, proteinuria. But in addition to that, there is thrombocytopenia and abnormal liver enzymes. Eclampsia globally and preeclampsia is the third leading cause of maternal mortality. It accounts for 16 to 31% of perinatal deaths globally. The case fatality rate in developing countries is 14%, and preeclampsia affects 2 to 8% of all pregnancies. In Jamaica, hypertensive disorders in pregnancy is the #1 killer and accounts for 18% of maternal deaths. The complications include antepartum hemorrhage, postpartum hemorrhage, and fetal miscarriages. So, timely intervention is necessary to reduce the complications associated. These are the hospitals that we look at. They're Victoria Jubilee, Spanish Town Hospital, University Hospital. So the objective of this study, really, we aim to describe the maternal and fetal outcome in women with eclampsia and preeclampsia who delivered at these hospitals between January 2015 to December 2019. It is a retrospective cohort study at the 5 maternity hospitals, and the study population were women who were managed for eclampsia and preeclampsia. Included in the study were women admitted to the 5 hospitals during the 5-year period and their neonates, including those who were discharged. Women with known seizure disorders were excluded from the study, and those whose seizures were attributed to another cause. Previous studies estimated that the case fatality of eclampsia in developing countries to be about 14%. Assuming this figure and applying 95% confidence level and 5% margin of error, the minimum required sample size for eclampsia was 132 dockets. The sample frame was constructed for each hospital, where a list of patients with eclampsia and preeclampsia was used to select all of the eclampsia patients, 1 in 4 of preeclampsia patients, and normotensive women were conveniently selected, giving a total of 788 women for the study. Data was collected from various sources, including the electronic system with ICD-10 code, the delivery books, antenatal registers, and postnatal ward, the admission books for the female medical ward and the nursery, also the death registry. 2 trained healthcare workers using a data extraction sheet with 8 sections were used to collect maternal obstetric and delivery information and neonatal birth and discharge information. SPSS 21 and status 16 was used for data processing and analysis. Summary measures were expressed as means with standard deviation or as proportions. Cross-tabulation was performed to demonstrate the relationship between preeclampsia and eclampsia and normotensive women. Chi-square analysis was used to test the association with eclampsia and preeclampsia. Logistic regression was used to determine factors associated with these conditions. Regression model was considered for eclampsia and preeclampsia versus no hypertension. A p-value of less than 0.05 was considered to be statistically significant. Data were presented in tables, graphs, and charts. Maternal and fetal outcomes were examined. The incidence of eclampsia in Sarah between 2015 to 2019 was 2.4 per 1,000 live births. This is for a parish of residence versus parish where the care was accessed. The case fatality rate was higher among women diagnosed with preeclampsia. For the study population, the mean age was 27 years, with a minimum of 13 years and a maximum of 48 years. Most women who had eclampsia were less than 20 years, as seen in the dark blue color, and among all the age group, preeclampsia predominates, seen as the green color. Eclampsia was seen among the younger women with a median age of 22 years and interquartile range of 18 and 27. This population, they were single and unemployed. Women with eclampsia had a mean number of antenatal visits of 5.6, with a standard deviation of 2.8. This was least compared to women with preeclampsia and those who were normotensive. We are providing data here in change in weight from the first antenatal visit to the last antenatal visit. What we observed was weight gain between the first and last antenatal visit ranged from 4.6 kilograms in eclampsia to 8.7 kilograms in preeclampsia. And this was significant association. Women with hypertensive disorders in pregnancy experienced several symptoms. The prodromal symptoms for eclampsia were headache, flashing lights, and dizziness, while those for preeclampsia was mainly swelling of the hands and feet and epigastric or abdominal pain. And this association was significant for the two conditions. The significant common obstetric complications observed were postpartum hemorrhage and HELLP syndrome. Let's look at the outcome. The odds of baby dying or developing severe complications are particularly high when preeclampsia and eclampsia occur. The risk of premature birth was 22 and 19 times more likely in women with preeclampsia and eclampsia respectively compared to neonates of normotensive women. Women with eclampsia developed neonates who were 14 times more likely to be admitted to the nursery and 12 times more likely to experience fetal death. Eclampsia was seen in the less than 20 years age category in keeping with other studies. In fact, studies reported less than 17 years, suggesting the increased liability of the central nervous system response in teenage mothers. What was also interesting with this group is that they had the least weight gain throughout the pregnancy from the first to the last, in that they were not obese. This study supports similar findings of literature which report eclampsia patients were on book, and eclampsia patients here also had less than 4 antenatal visits as recommended by WHO. Headaches was the most common symptom. In fact, women would say that this was the worst headache they had in their lives for those who had eclampsia. The odds of neonates admitted to the nursery or dying was seen in this study was in keeping with other studies. In fact, over 60% of the eclampsia women had cesarean section delivery. The research findings actually provided a good estimate for this population, but cannot be generalized. It was not a countrywide study. Some variables could not be reported in providing some information gap. In Jamaica, where maternal age at childbearing is increasing, the association of hypertension with advancing maternal age will undoubtedly contribute to a greater prevalence of eclampsia and preeclampsia and their potential adverse outcome for pregnant women and their infants. This useful information collected can contribute to filling the gaps in the maternal mortality morbidity research agenda. It will also guide practice and policies about the most frequent complication and organ dysfunction related to preeclampsia and eclampsia. Jamaica does not have an electronic inpatient name system that provides an efficient way of cross-checking patient records across hospitals by assigning a unique number for each citizen, and therefore this is limited data available within hospitals and across regions for proper reporting and epidemiologic function. This highlights the need for technological advances that can improve patient care and patient record management. Hence, there's need for a universal electronic management. We need to strengthen specialized maternal health within each tier, monitoring and consistent professional assessment. For the ICD 10 and 11 discharge coding to be taught and monitored throughout the region. It is in use, but it needs to be monitored and ensure it's being done. These are my references, and I want to thank those persons who have been assisting, including my supervisor, my program coordinators, my lecturers, the support team, the healthcare workers, and my support team, including Mrs. Alfred, Williams, my family and friends, and those who have been. Thank you very much.
All right, thank you, Dr. Lord. So you'll stay online until the next presenter does her presentation and for the discussion and question and answer. Our next presenter is Miss Selena Lewis. You can make her welcome.
Good afternoon, everyone. I am Selena Lewis, and I just want to start by thanking the Ministry of Health and Wellness for hosting this research conference and giving me this opportunity to present. I'll be presenting on the findings from my master's thesis, the association between sleep duration, hypertension, and PCOS in women from the UK Biobank, a case control study. Polycystic ovarian syndrome, also known as PCOS, is a hormonal condition that affects women of reproductive age, resulting in hormonal imbalances, irregular periods, excess estrogen levels, and cysts in the ovaries. Some cardiometabolic outcomes associated with PCOS are obesity, insulin resistance, diabetes, hypertension, and cardiovascular disease. Sleep is important for rest and recovery, cognitive function, emotional well-being, physical health, hormone regulation, brain health, heart health, longevity, pain management, and hormone regulation. Majority of the studies done have focused on sleep-disordered breathing. However, it is important to understand how sleep duration and sleep quality affects women with PCOS. In this study, we'll be focusing on sleep duration. Previous studies for women in general have found that short and long sleep duration is associated with hypertension. Short sleep duration has been found to be associated with increased blood pressure and nocturnal hypertension. The objective of this study is to investigate the association between sleep duration and polycystic ovarian syndrome, PCOS, and the association between sleep duration and hypertension among women from the United Kingdom, UK, Biobank. We conducted a case control study of women aged 40 to 70 years with and without PCOS from the UK Biobank. The UK Biobank consists of 500,000 participants. We excluded all the males, leaving us with 273,469 females. We went further to do a random one-to-one sampling of women with PCOS and without PCOS, which left us with 1,330 women after excluding the women without PCOS that were not a part of the random selection. We were left with 727 women with and without PCOS with no missing data. These are the variables that were used from the UK Biobank in this study. Hypertension, sleep duration were the dependent variables. The independent variable was PCOS status, and we used, for the confounding variables, age, ethnicity, alcohol intake, smoke status, shift work, body mass index, physical activity level, chronotype, which simply means their level of alertness, the best time throughout the day that they're alert or awake, depression, and type 2 diabetes. Sleep duration was self-reported as whole numbers and were placed in 3 categories. Short sleep was less than or equal to 6 hours, adequate 7 to 8 hours, and long greater than or equal to 9 hours. Participants were asked if they were previously diagnosed with hypertension. In the UK, hypertension is defined as a blood pressure reading of greater than or equal to 140/90 millimeters mercury based on the National Institute for Health and Care, NICE guidelines. For statistical analysis data, the standard edition 16.0 was used to conduct data analysis. Descriptive analysis were generated to characterize the study cases and controls. The association between sleep duration, hypertension, and PCOS were assessed using multivariable logistic regression models. Results. It was found that we had 420 women with PCOS in our sample and 307 women without PCOS in our sample. We found that women without PCOS were younger. The women with PCOS had a higher percentage of being of African Caribbean ethnicity. And the women with PCOS reported having a higher BMI. Women with PCOS also reported having a higher percentage of depression, higher percentage of physical inactivity, and a higher percentage reported being of evening chronotype, or level of awareness or alertness throughout the day, compared to women without PCOS. Sleep duration was not significantly different between both groups. Hypertension status was not significantly different between both groups. Sleep duration was not found to be associated with PCOS status in this study, and hypertension status was not found to be significantly associated with PCOS status. In this model, the regression model for the association between sleep duration and hypertension in women from the UK Biobank adjusted for age, BMI, ethnicity, type 2 diabetes, physical activity level, alcohol intake, and depression. When we checked for interaction with PCOS and sleep duration, no interaction was found. We found that long sleep duration was significantly associated with a 4 times higher chance of having hypertension regardless of PCOS status. Women with PCOS did not have a significantly higher risk of having hypertension compared to those without PCOS. PCOS was not associated with sleep duration. Short sleep duration was not associated with hypertension. However, long sleep duration was significantly associated with hypertension. What does this mean for Jamaica? PCOS is prevalent in the in the black population based on previous studies and based on my own findings from this sample size. High prevalence of hypertension is found among women with PCOS based on previous studies. However, this may not have been seen in this finding because it was predominantly a white population that was used. Jamaica is known to have a high prevalence of hypertension. Hence, more investigation needs to be done in the Jamaican population to tackle this issue. In conclusion, sleep duration was not found to be associated with PCOS. Sleep duration, specifically long sleep duration, was found to be significantly associated with hypertension independent of PCOS status. Thank you. I'd like to just say a special thank you as well to Professor Marshall Tolleril, Professor Ferguson, Dr. Bennett, Professor Anderson, Dr. Susan Chang-Lopez, and Mr. Blake for their guidance and support. Thank you very much.
Thank you, Ms. Lewis. And just another round of applause for 3 great presentations on reproductive studies. And I'll open the floor now for questions and answers from the presenters. Any questions from the online platform? Okay, not as yet. Okay, we have a question in the room. No, Dr. Edwards is after, but Ms. Tasmoyne. Dr. Crawford? Was it Dr. Crawford? Dr. Crawford and then Dr. Edwards.
Ladies before gentlemen, huh? I was just wondering why 3 health centers for the presentation on impact of COVID-19 on the health care facilities. Earlier you mentioned 3, in the beginning of your presentation you mentioned 3 health centers. I was just wondering why you singled out 3.
All right, so that's for Ms. Michael.
Oh, type 3 health centers?
Oh, it's type 3?
Yes, type 3.
Across the island?
Yes, so basically from all parishes. But since it's a bit hard missing data, so we had to exclude it in the analysis.
Okay, thank you.
Ms. Michael again. Now, I was trying to anticipate what the results would be before the talk. I would have expected all clinics to have gone down during COVID. But I was surprised to see that the family planning clinics went up, the numbers. No, I'm married woman. I was wondering the age group of these women, was that looked into? The age group of women who were attending this clinic? Was it the teenagers? Was it the under 16s? I don't know. I'm very curious to know.
Hold on. I'm coming to the rescue.
If I may, though, to follow up on that same question, I know that one of the challenges in primary care for women accessing family planning services is the fact that a lot of them work. And I'm wondering if it was because persons weren't at work and at the time that had contributed to them being able to access the service. I was just thinking why it went up, yes.
Yeah, Yes, that could be a reason, and we're also thinking about possible unemployment, so that may have pushed persons to get more family planning methods to avoid pregnancy during that financial difficult time. That's it.
All right, I see Dr. Grant has her hand up. Can she get a mic?
I think yes, I can be heard. Yes. Good afternoon again. Yes, good afternoon again. I want to, first of all, congratulate the three presenters on excellent presentations, each one very interesting. I would like to ask a question of Ms. Lewis with respect to the sleep duration and the longer sleep duration and hypertension. I thought that finding was interesting and wondered what are your thoughts in terms of explaining that finding?
Can you repeat the last part of the question for me, please?
Yes, I was asking you to further explain the finding of the association of longer sleep duration with hypertension.
And hypertension.
Yes, thank you.
Okay, so previous studies have found that short sleep duration has an association with hypertension. However, there has not been a conclusive study as yet to show that long sleep duration is associated with hypertension. Some studies show an association, some studies don't. So I think further investigation just needs to be done to understand why that's the case, if there are other confounders that might be present in that association, why it can't yet be concluded. Yeah.
I have a question for Dr. Lord.
Dr. Crawford, another question.
Yes.
Who is
this
it
is for Dr. Lord.
Dr. Lord is, okay, so Dr. Lord is online. Dr. Lord, no, this question is for you.
Okay. Given where Jamaica is at regarding maternal mortality and the increase that we had seen during COVID-19 and what is happening now, what programs have been put in place in order for us to even close to meeting the SDG target pertaining to maternal mortality? Over.
Thank you. Thank you for that question. Actually, there are several programs that have been in place. There's actually closer monitoring. There are guidelines that have been developed to help streamline care within the various facilities, even though that is not part of this part of the abstract that was prepared. But there are several programs, there are guidelines that are being developed, and training has increased. There's also cases where there is plan to have education campaign. For this part of the study, this is a three-component study, and part was a qualitative assessment, what mothers feel. And what we realize is that in terms of education of mothers, that was actually on the low side. But what mothers were asking for is more testimonials being shared nationwide so that other mothers would be able to know about the life-threatening situation, for example, for eclampsia, because there are posters, there are flyers, there are talks at the antenatal clinics, and all of these have been going on. But what these mothers were saying Let mothers who would have experienced the condition come and tell us about their experience, and we will hear it more. And so in terms of education campaign, that is one area that we're going to be exploring on a more wider scale as it relates to decreasing the maternal mortality across the nation. But we have skilled health staff at the facilities, at the health centers. We have no problem with access to care, all right? We need to improve, and as PS has indicated and the minister has indicated earlier, we have to improve the technological access, like ultrasounds, and the investigative arm of our care offered to women. So we are going to get there. I am confident of that. We have the staff that is available. We are adding staff onto the system. And so I'm optimistic about what to look forward to as it relates to decreasing our maternal mortality to less than 70 by 2030. I'm optimistic about that.
All right. Thank you, Dr. Lord. I have a question for Ms. Lewis. We note the finding that sleep duration was not associated with polycystic ovarian syndrome, is what you set out to investigate. So I was wondering what was the hypothesis behind that and what did previous studies say?
So my hypothesis was that sleep duration was associated with PCOS. Previous studies have found that women with PCOS do tend to get a shorter duration of sleep. And based on that knowledge, we know that sleep duration has an effect on hypertension. So I wanted to find out if there was some relation with the shorter duration of sleep that women with PCOS are getting with the prevalence of hypertension among women with PCOS. So I, in turn, kind of rejected my hypothesis.
All right, thanks, Ms. Lewis. Any questions from the online platform? Any other question in the room? All right, not hearing any. So I don't sleep too long. No, long sleep is associated with hypertension. Okay, that was a joke. So just give a round of applause for 3 wonderful presenters and presentations. And we bring this session to a close. I think we're going to have a stretch break or Jamaica Moves break.
Three, 2 more, 1, 2. Adults to 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right.
We have come to the close of another wonderful session, and at this time we want to thank Dr. Ardeen Harris for her excellent moderation. We thank her for taking us through this session. We also want to thank our presenters, and at this time we want to present a small token to Dr. Harris. Thanks again.
Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. 1, 2. After 2, make me hear you say I love me. 1, 2. 1, 2. 1, 2. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up.
Love your body, treat your body right. Love your body, treat your body right.
One, 2, 3, 2 more. 1, 2. Adults the 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Make sure you know your health status. Go a doctor and get a regular checkup. Chronic disease can slowly creep up. We can lower the risk and live up if we just eat right and get moving. Jumping, running, dancing or skipping. Change the children, them lazy habit. Make them play out the door and put down the tablet. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. 1, 2. 1, 2. After 2, make me hear you say I love me. 1, 2. 1, 2. 1, 2. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up.
Love your body, treat your body right. Love your body, treat your body right.
One, 2, 3, 2 more. 1, 2. Adults the 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Make sure you know your health status. Go a doctor and get a regular checkup. Chronic disease can slowly creep up. We can lower the risk and live up if we just eat right and get moving. Jumping, running, dancing or skipping. Change the children, them lazy habit. Make them play out the door and put down the tablet. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After two, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. I love me. After two, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. I love me. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up.
Love your body, treat your body right. Love your body, treat your body right.
Good afternoon. Good afternoon. Those of us who are here in person and those of you online, welcome to our 6th session, which is entitled Social Support and Mental Health. I'll be your moderator. I'm Dr. Kevin Goldburn, Director of Mental Health Unit within the Ministry of Health and Wellness. As you can imagine, I'm very interested in these presentations that will be coming up shortly. So we have 4 presenters. And the first one is Dr. Keon Donaldson Davis, and she's coming to us from Mona Aging Center at the University of the West Indies, where she works as a lecturer since 2018. She has worked extensively in Jamaica and the British Virgin Islands in the areas of urgent care and community medicine, and she has a passion for public health, primary care, and care of older individuals. Our presenter has worked with the elderly or geriatric guru, Professor Denise Eldemire Shearer, in the development of a new geriatric training program for medical doctors, which was launched in January 2021. Our research spans the disciplines of public health and aging, with focusing impact of COVID-19 on older persons and long-term care provision in Jamaica. As you know, that's very relevant because during COVID-19, the message that was sent out to the older persons that they must stay home. And we know it had a lot of negative impact, which I've heard Professor Elimaya Shah repeat several times. This afternoon, she's going to present to us social support and risk for cognitive impairment among community-dwelling older persons in Jamaica. Please make her welcome.
Good afternoon, everyone. Thanks, Dr. Gober. All right, so today's presentation is entitled Social Support and Risk for Cognitive Impairment Among Community-Dwelling Older Persons in Jamaica. Now, population aging is in effect. It is a change in the composition of the population where older persons account for an increasing share of the total population. In the Jamaican setting, population aging has come alive in that older adults account for 13.5% of the total population, which amounts to 379,000 older persons in Jamaica. The share of older persons, meaning those 60 years and over, has increased by 13.8%, while the general population has seen an increase of only 0.6% over the 2014 to 2019 period, and this is based on post-census estimates from the Statistical Institute of Jamaica. So, just a little bit about mild cognitive impairment and dementia. Mild cognitive impairment is basically an early stage of cognitive ability loss, including memory, language, as well as visuospatial perception losses. But these individuals are able to maintain the ability to independently perform most of the instrumental activities of daily living. Dementia is an umbrella term for a number of neurological conditions, of which the major symptom is the decline in brain function due to physical changes in the brain. So, Alzheimer's disease as well as vascular dementia are examples of dementias. Now, in terms of the burden of mild cognitive impairment and dementia, approximately 10 to 20% of persons who are 65 years and over with mild cognitive impairment develop dementia over a 1-year period. This is information out of the United States from the National Institute on Aging in 2021. In terms of the global burden, the prevalence of MCI stands at about 19.7%. The prevalence of dementia ranges between 5 and 7% in the 60-year and older age category, which amounts to a whopping 57.4 million people living with dementia worldwide. In Latin America and the Caribbean, mild cognitive impairment, the prevalence of mild cognitive impairment ranges between 6.8 and 25.5, and dementia prevalence stands at about 10.66, which is notably higher than the global prevalence. In Jamaica, studies done by Eldemar et al. In 2018 showed that the prevalence of dementia stands at 5.9%, which is comparable to international or global prevalence data. Now, the thing with dementia is that its diagnosis begins with screening, and there are several screening tools that are widely used to assess both mild cognitive impairment and for dementia. And for the purposes of this presentation, we'll be looking at the mini-mental status exam. Now, in 2012, there was a health and social survey done of the older persons in Jamaica, and this paper is an analysis from data from that 2012 study. In the method, I will provide some general information on the methodological approach and used in that study, and for the remainder of the talk, I'll walk you through the data analysis done for the purposes of this paper. So the objectives of that study is that it were to assess the health and social status of older persons in Jamaica, as well as to identify the needs of the older adult population. Now, with respect to the method, in 2011, there was a sample of 2,943 older persons that were drawn from the southeastern parishes of Kingston and St. Andrew, St. Catherine, and St. Thomas. Now, for recruitment, we utilized a two-stage cluster sampling method. The first cluster units were chosen from enumeration districts across those 4 parishes with I'm sorry, they've started the wrong version of the presentation, and so the slides are not what I'm expecting, so my apologies. So the first cluster units were enumeration districts across the 4 parishes with the probability of selection of each enumeration district proportional to its size. The second stage of random selection were households, where one household represented one individual. So there were 35 clusters chosen from the enumeration districts, and then 85 individuals per cluster, which amounted to the 2,943 participants. In terms of the data collection tool, a questionnaire was used, and it explored some major domains, which included demographic and socioeconomic factors. And there were some standard instruments as well that were used, including the mini-mental status exam. So the objectives of this paper were to describe the social support among older Jamaicans by mini-mental status exam scores, as well as to identify relationships between social support variables and mini-mental status exam scores. Now, MMSE scores were available for 2,782 participants, and there were some key variables that were explored that were considered social support indicators. So the variables were number of children alive, caregiver presence, quality of relationship with children, source of main physical support, as well as source of main emotional support. So those were the indicators. In terms of our data analysis, we use version 20 to analyze the data. Confidence intervals were generated with a level of significance of 0.05. Mini-mental status scores were dichotomized and scores less than 20, dichotomized to scores less than 20 and those of 20 and above. For the purposes of this study, the mini-mental status scores between 0 to 19 were designated lower scores. A logistic regression model was created which incorporated age, sex, highest education level, as well as the social support indicators that were listed on the previous slide. In terms of the results, mini-mental status scores range between 0 to 30. The median score was 20 with an IQR of 7. Now, there's a table that I prepared for you, which showed the socio-demographics, the support indicators, as well as the mini-mental status exam scores. Now, the significant findings were that females were more likely to have lower scores than their male counterparts. The median age for persons in the lower score category was higher at 76 years than those, and it was higher than those in the higher score category where the median age was 71 years. And of note, there were no differences noted regarding the number of children alive by score category. A few other important findings were noted. So those among the persons whose scores were considered lower, 8.9, so close to 10% of those individuals rated the quality of their relationship with their children as poor or non-existent. And the majority of persons in the lower score category also considered their main source of physical support to be themselves. The plurality of individuals who were in the lower score category also considered themselves their main emotional support. Other findings included the fact that 73% of persons with lower scores had no caregiver. 1/10 of persons with lower MMSE scores had no children, and it further lends credence to the fact that, or supports the fact that 8.9% of persons with a low scores, 8.9% of persons among those who had low scores rated their relationships with their children as poor or non-existent. So poorer quality relationships with children were more likely among those lower MMSE score category. Persons with caregivers were more likely to be in that lower score category as well. And older age, as well as a primary level education and below, were associated with lower MMSE scores. Just a few points to discuss. Only a few studies were out there that looked at social support needs of persons with cognitive impairment, and those studies were predominantly found in the North American as well as Asian spaces, so like in China, for example. But there was limited data on this type of assessment found for the Caribbean countries, Jamaica included. Our results are very similar to prior studies that were done, which showed that persons with milder dementia generally reported lower perceived social support. Our paper had a few limitations. One, first of all, the perception of social support may be impacted by cognitive function, as alluded to in previous studies. Social support indicators are more numerous than those captured by this study, so therefore a generalization is not possible. Social support indicators, when applied in the context of MMSE scores, may not accurately capture the need for social support, okay, especially since a low MMSE score does not by itself speak to the functionality of individuals. So, in conclusion, lower MMSE scores are known to be associated with an increased risk of cognitive impairment. Many community-dwelling older persons at risk for mild cognitive impairment actually lack the adequate social support that they need. Persons with lower MMSE scores should receive close clinical surveillance once identified through screening, and be prioritized for community-based social support interventions. Programs incentivizing caregiving can benefit those who have mild cognitive impairment or dementia. Excuse me. Further exploration of the nexus between cognitive impairment, social support, and level of functionality in the Jamaican setting is warranted. Thank you. Sorry.
Thank you very much, Dr. Donaldson Davis. Sorry you weren't able to show your slides, but I think we still got the message from what you were saying about social support and the elderly. So I will go to the next presenter, and then after the next presenter, we have some questions before we go to the last two presentations. So our next presenter actually presented before. Her name is Ms. Selena Lewis. She's an epidemiologist and research assistant in the Epidemiology Research Unit of the Caribbean Institute for Health Research. And she's currently assigned to the Caribbean and South America team-based strategy to control hypertension, otherwise called CATCH study. Ms. Lewis holds a bachelor degree in basic medical sciences with specialization in anatomy, first-class honors, and a master in science in epidemiology. In 2021, she received the National Scholarship for Mathematics Science for postgraduates in honor of the Honorable Dr. Mavis Gilmore Peterson, a former Minister of Health. And her primary aim, as you heard in the presentation before, is on PCOS, and she will now be presenting to us on the influence of health systems and patients' experiences on self-reported medication adherence in Jamaica and Colombian patients with hypertension. It's a cross-sectional, cross-country comparative study. Please make her welcome.
Good afternoon. I'll be presenting the findings on the self-reported medication adherence in Jamaican and Colombian patients with hypertension, a cross-sectional, cross-country comparative study on behalf of Professor Marshall Tullereed. Non-adherence to hypertensive medications can result in uncontrolled high blood pressure, suboptimal clinical outcomes, and avoidable healthcare expenses. Factors contributing to non-adherence are multifaceted and can be classified as patient factors, provider factors, health systems, facility factors, and community factors. In this study, we'll be focusing on health systems. The World Health Organization, WHO, defines health system as a group of connected, interdependent parts, individuals, organizations, and actions whose major objective is to preserve, restore, or improve health. Jamaica and Colombia has differing population sizes. Jamaica has a smaller population size. This data was taken from PAHO. Jamaica is predominantly black. Jamaica has a shorter life expectancy. Jamaica has a lower literacy rate and a lower public health expenditure, GDP, compared to Colombia's population. Jamaica and Colombia's health systems are different. Jamaica's public health system is primarily through government-run and sponsored clinics and health facilities using paper records and is free of charge at point of service, while Colombia's public health system is through practitioner offices and facilities contracted by government through insurance companies to provide care to patients using an electronic medical record system through a public health insurance plan, meaning everybody in Colombia has a health card. The objective of this study is to examine whether differences in the Jamaican and Colombian health systems influence self-reported medication adherence among hypertensive patients, independent of patient characteristics and healthcare experiences in each setting. The CATCH study, known as the Caribbean and South America Team-Based Strategy to Control Hypertension, is a National Institute of Health NIH-sponsored study to improve hypertension in the Caribbean and South America. It is a 6-year study with 3 phases. The planning phase, which lasted for 2 years, the implementation phase, which we are currently in, which will last for 2 years, and the scale-up phase. We will be using the data being presented will be taken from the planning phase of the study from the needs assessment questionnaire. The study was conducted in primary care clinics in both countries in 2021. Colombian patients were selected from an electronic medical record system, while Jamaican patients were identified from clinic attendees on hypertension treatment days from randomly selected primary care clinics. All interviews were conducted by telephone in both countries. From the needs assessment questionnaire, we extracted the following variables: socio-demographic, hypertension knowledge, patients' healthcare experiences, and medication adherence. Medication adherence was measured using the Impact Mass Medication Adherence Scale using 2 questions. The first question, over the last 7 days, on how many days did you not take any blood pressure pills? And the second question, over the last 7 days, on how many days did you cut back or not take the full dose of your blood pressure pills? The responses from the participants were totaled, and if they got a score of 6, they were considered to be high adherent. A score of 5 or 5.5, they were considered medium adherent, and less than 5, they were considered to be low adherent. From our sample, we had 288 patients in Jamaica, 288 patients in Colombia. We found that our Jamaican population were younger. Our population sample were younger. Our Jamaican patients reported less percentage of Jamaican patients reported having a more than high school education compared to Colombia, and a lower percentage of Jamaican patients reported being in a married or common law relationship compared to Colombia. These results were significant. There was no significant difference in sex and hypertension knowledge. There was a lower percentage of Jamaican patients that reported doctor discussing blood pressure treatment plans compared to those in Colombia, and a higher percentage of Jamaican patients reported pharmacists discussing substitution of medication compared to those in Colombia. Doctor discussing medication changes was not significantly different in both countries. Medication adherence was significantly different between countries, Jamaica in blue and Colombia in orange. Colombia had a higher percentage of patients reporting high adherence compared to those in Jamaica, and Jamaican patients reported a higher percentage of medium and low adherence. When we did our regression model, unadjusted, we found that Jamaican patients had reported as 7.3 times more likely to report low, medium medication adherence compared to those in Colombia. When we went further to adjust that model for age, sex, education, urban rural status, and hypertension knowledge, the odds ratio changed to 7. When we adjusted for doctor discussing treatment plan and doctor discussing medication changes, the odds ratio changed to 6.6 but remains significant. When adjusted once more for pharmacists discussing medication substitution, the odds ratio changed to 6. However, it remains significant. In conclusion, patients within Jamaica's health system were more likely to report low, medium medication adherence compared to patients within Colombia's health system. Differences in patients' healthcare experiences did not significantly impact the influence of the health systems on self-reported medication adherence. The CATCH study allows us to do further investigation to understand factors in the health systems that influence patients' medication adherence. Thank you. Special thanks to the Ministry of Health for hosting this conference, and Professor Marshall Tollereid for giving me this opportunity, Professor Ferguson, Dr. Susan Chang-Lopez, Dr. Bennett, Mr. Blake. Thank you for your guidance and support.
Thank you, Ms. Lewis, for a very important presentation, because as we know, adherence, especially non-communicable disease, one of the biggest issues to how to improve adherence. So at this point in time, I want to see if there are any questions online. Are there any questions online? Okay, there are no questions online. Are there any questions in the room? I'm sure there are questions in the room for the two presenters who have presented so far. Please go ahead.
Good afternoon. I have a question for Dr. Donaldson. Reflecting on your study, you had mentioned the impacts of lower social support for patients who are living in the community setting. Now, when you consider patients living in institutionalized settings in the government sector, what recommendations would you make to improve their outcomes, considering that they have less social support traditionally?
Recommendations. Well, the recommendations would be basically uniform for the group of persons who are considered vulnerable, which is to identify the areas of need, whether the social support pertains to family support, or it pertains to physical support, financial support, whatever the aspects that we have identified as areas of needs or gaps, then these are areas that need to be addressed using various platforms, may include various approaches to resolution, or to, the recommendations would be wide and varied because of how comprehensive social support is as an indicator, right? There are several points or aspects that you could explore. In fact, there are some standardized tools and validated instruments that are available that can assess social support on various levels. So whatever the needs are that are identified, whether the person is within the community setting, within the home setting, within the institutional setting, then it is just for us to identify them and address them as best as we can. Right. But expect them, especially among those people who have cognitive impairment.
Right, so in terms of what you describe is basically strengthening the social support, well, yes. But when it comes on to persons with memory impairments, yes, would you advise implementing memory assistance programs, whether it be through the public health clinics? Because that may also be a significant factor in poor social support, is that family members don't know how to exactly help people with lesser cognitive function as they age. Would that be feasible?
Absolutely, absolutely feasible, but any sort of intervention that is required begins with identifying these vulnerable groups, so checking for them and monitoring them and seeing what their needs are, and then addressing them. As you said, this is one way in which the needs can be addressed, but the first step is really identifying the individuals and monitoring them to see what it is that they need, because memory aids and memory support and so on is just a very small aspect, an important aspect, albeit, but a small aspect of the level of care, the level of the types of interventions that are required for this group. So yes, to the answer to your question, for sure.
Thanks much, Doc.
You're welcome. Yes, of course.
So thank you, Doctor, for your presentation. And I'm glad to hear that the mention was made. I just want to give you a chance. That the children are an important factor, and the number of, and how they relate to the parents are important in terms of decreasing the impact of dementia. But did you explore other support from other community organizations like churches and other organizations? Did that play a factor in the outcome?
All right. So to answer the question, strictly speaking, no. So the answer is no. But on the basis that the original aim of this study was never to elucidate social support, we secondarily looked at this because we see that this area, the body of information surrounding social support for persons who are cognitively impaired is limited, right? But when saying so, social support can extend from beyond this family setting into what exists within the community setting, friends and external circles and so on. So it is for further studies to explore what exists out there. We know that the church and other faith-based organizations play a pivotal role in providing social a social circle for older persons especially. So I have no doubt in my mind that there would be a significant contribution from that aspect. But it hasn't been documented, but it certainly is something to look at.
All right. Thank you, Doctor, for your presentation. I was listening carefully. I would have been glad to have some visual while the presentation was going on. So I have to be scribbling some notes. So what are some of the indicators that you used in your studies? Did I hear well? Number of children who are alive?
Yes.
Okay. And then I see something about 0 to 19 were lower score. That was said? Okay. And female had lower score. All right?
Mm-hmm.
So I was wondering, and then there was this point I jotted down. Said they had their relationship with their children were poor. How could that be? No. I've been here 23 years. I'm not just coming. The thought line shouldn't be that the relationship of the mother with their children is poor. But this is what you are finding in the studies. Am I correct? Because I took note, I'm sure. I want to be sure.
We are saying that 8.9%
yes,
of persons
I know that
who had a low score rated their relationship. So it is the minority of persons.
Yes.
But we're saying that because it is a vulnerable group, as small as the percentage point is, it is still significant because there is still a gap that exists among these vulnerable individuals. You can't take it for granted, in other words, that, once children are on board, yes, persons may have four children on average, but that this relationship is going to be solid and that there is going to be a cushion for them in terms of care.
Okay, so that was why I put that. That's why I wanted to get clarity on that.
Thank
because
you.
The greater majority is the opposite of what this is.
Sorry,
no.
I didn't hear this last point.
I said the greater majority
yes.
would have been the opposite of this 8.9.
Absolutely.
Okay.
Absolutely.
Then I had this point here, sorry. Persons with care were in that age as well. What do you mean, persons with care?
Persons
who
with
got care, people were attended to.
Right.
Were also in the age group that had low score.
So we're saying that 78% of persons with low scores had indicated that they had no caregiver. Now, whether or not they absolutely needed a caregiver functionally is outside of the scope of what we examine. But again, it's just a conversation starter to the fact that here we have a vulnerable group of persons who may have an impairment in their ability to think. And they are saying, the majority is saying that they have no caregiver on board. Right, and to me, it's certainly worth more exploring. What's happening here? Is it that the majority do not need a caregiver? That may very well be so, but it is still for us to pay some attention to the fact that this group of persons may need help, and we're overlooking them.
Yes, thank you. I have it. Thank you.
You are welcome.
Thank you. Then I have a next question for Louis. Can we ask Louis?
I have a question for the lady who just sat down.
Yes.
Yes. Social support within the context of your research,
yes.
Did it take into consideration social protection any at all?
Social protection.
Okay.
We simply looked at the indicators that I had listed on my slide that we didn't see. But it just explored those variables that were accessible to us from this data that we were able to secondarily look at. So unfortunately, we didn't go into the realm of social
protection.
Social protection.
Well, it could be considered as a way
Absolutely.
forward for program policy
Yes.
objectives for your social support
Yes,
program.
and that is one of the domains that is explored in some of those validated tools that exist that look at social support as well. Thank you very much for your question.
Okay. Miss Lewis, thank you for your presentation. Yesterday I was in the room and somebody presented something about Colombia. And then I asked a question, what is happening between Colombia and Jamaica? And I hear the young person telling me that the health system were different. But your research is telling me there was no difference between the health system. Did I hear that? I just heard that.
So my study shows that there is no difference that there is a difference with medication adherence between both health systems. When we adjusted for patient experiences, we found that those did not contribute to that difference. So I'm not sure if I...
Okay, that's
all right.
okay. That's
Okay.
okay. Calm down, no problem. We just want to have a discussion. So you realize that in Colombia, everybody have health card.
Right.
But in Jamaica, we all don't have. So it depends on your ability and capability to buy yourself one or get one or be in a space where you can afford. So wouldn't that have made some difference in the adherence to the medication? Because here we talk, when we go to the pharmacy, can you give me the cheaper one? Which one? If this one, doctor, I prescribe. So is that a good thing by your... No, listen now, just you and me. Is that a good thing?
Okay. So further studies need to be done to understand why is it that there is that difference with the medication adherence within both health systems. If it is a case wherein when we do those further studies we find that it is the health system itself that is the issue, then changes would have to be done to implement a new form.
What if money is the difference?
What is the difference?
They don't have money.
Is money the difference?
Yes, they have to purchase the medication. It's not free.
Well, if money is the difference...
Someone pays for it. Okay, even if it's free, someone pays for it. No, so. All right, so thank you.
Okay.
This I must wrap up. Thank you.
All right, thank you for
Good
the question.
presentation.
Thank you.
Yes, thank you, Ms. Lewis and Dr. Davis. And I also think that in difference between the two groups, between Jamaica and Colombia, I think it has to do with the fact that in Jamaica is a public system, whereas in Colombia is a private system. I think we need to look at the interaction, because in America we get a therapeutic alliance in the private system as opposed to the public system. And that's just from my psychiatric perspective. Okay, our next presenter is Ms. Shanae Linton, hope I pronounced her name correctly. She's a highly skilled registered nurse with a passion for healthcare and a commitment to improving the well-being of others. She's driven by a passion for addressing broader public health issues, and she is currently pursuing her Master of Public Health with an emphasis on health management. Through this program, she aims to enhance her knowledge of healthcare administration and management. Also of her professional life, she is a devoted mother and wife. Please make her welcome as she do her presentation. Patient satisfaction and factors influencing satisfaction in accident and emergency departments of Type A hospitals in Jamaica. Patrice is here. So before she presents, Patrice. Patrice to go first. So before you present Ms. Linton, we're going to ask Patrice, who's online, to present. So Ms. Patrice White-on-Simit, she's a clinical psychologist in training. She's currently pursuing a PhD at Curtin University in Australia. She's an advocate for mental health. She's a wife and a mother. And I know her quite well. She is very passionate about mental health issues. I'm a big advocate for mental health issues. And so she's going to present to us a paradigm shift in mental health, stakeholder perspectives on improving healthcare access for people with serious mental illness and chronic physical illnesses. Please make Mrs. Whitehorn-Smith welcome.
Hello, good afternoon, everyone. Are you able to hear me? I just want to make sure. Yes, wonderful. Thank you. I'm hoping you are able to view my slides. It is 4:30 a.m. in Australia, so sorry if I sound a little bit groggy. All right, today I will be talking to you about our study on a paradigm shift in mental health, the stakeholders' perspectives on how to improve healthcare access for people with serious mental illness and chronic physical illness. Now, firstly, I want to point out that this is actually a study that was done in collaboration between Curtin University and the University of the West Indies. So I want to recognize my Curtin-based team as well as Professor Abel, O'Shea, Dr. Lalwani, and so on from the University of the West Indies. And I'd like to thank those who...
Patrice?
Yes? Yes, are you here?
We're not seeing your slides. We're not seeing your slides.
Oh, I asked if I should share.
Very well,
Okay,
but not
sorry.
your slides.
All right, let's
Share
go.
slides.
Are you seeing it now?
It's coming up. It's coming up. Yes, we are seeing it now.
Oh, thank you so much. Sorry about that. All right, let me make sure I made them big.
Can you put on slideshow for us, please?
That's what I'm doing. Okay, there we go. Good. Right. So I just wanted to acknowledge the team. All right. So just for some background, people with serious mental illnesses relate to those who have schizophrenia and other psychotic disorders, bipolar disorder, and moderate to severe major depression. And research done globally has shown that these people have a higher rate of mortality and a significantly shorter life expectancy of 15 to 30 years than people in the general population. Now, this is a huge difference in terms of the years lived. This has been found to mostly be due to the high rate of chronic physical illnesses among people in this population. And this tends to be mainly non-communicable diseases such as cardiovascular diseases, diabetes, and cancer. Within this population, cardiovascular disease is up to 12 times more common. Diabetes about 3 times more common. Within low and middle income settings, it is estimated that between 10 to 68% of people with serious mental illnesses also have chronic physical illnesses. Now, one of the number one barriers or challenges why they feel like people in this population are more prone to physical illnesses is the challenges that they face when they're trying to access health care. And it's so serious that chronic physical illnesses account for 70% of the mortality rate among this population. Now, why is access to care such a big issue? The access to care based on this study is defined as the ability to identify healthcare needs, to seek help, to reach it, and to obtain it. Now, the concept that was used in this study to assess healthcare access is based on Levesque, who identified 10 dimensions of healthcare access. There are things on the service arm that looks at how accessible the health system service is itself. And then there are individual factors that actually determine if people access care. And as you see in this diagram, they're parallel. So healthcare needs to be approachable, and the person also needs to be able to perceive that they have a healthcare need. It has to be acceptable, meaning that within the cultural setting, the norms and the values of the culture allow you to be able to go to the health center without any problems. And you must have that capacity to seek care. Health services must be available and able to accommodate you, and people should be able to reach. It needs to be affordable, and people have to be able to pay. and it has to be appropriate. Now, this level of access speaks to quality of care. People have argued, how does quality of care connect? It does, because if I have a healthcare need, I approach a health service, but my healthcare need is not addressed. I really haven't accessed healthcare. So these are the dimensions when I'm talking about healthcare that I'm actually looking at in this research project. Now, just to give some Jamaican-based background, we know that non-communicable diseases are the leading cause of death in Jamaica. And although there have been efforts to integrate mental health care into primary care, research over quite a number of years has shown that primary care physicians do not regularly screen for mental illnesses, and that the mental health services don't provide a comprehensive management of physical and mental illnesses. So far, there's been a lack of research that looks at healthcare access for this specific population who are highly vulnerable. Now, this study that I'm presenting is a part of our broader mixed method study that's looking at the overall enablers and barriers to healthcare access for this population. But specific for this presentation is I'm going to be focusing on what are the recommendations that were given for how the healthcare system response can be improved. Now, this part of that I'll be presenting on is a qualitative study. So we used a constructivist grounded theory approach to be able to develop a localized theory about enablers and barriers, as well as approaches that need to be taken for improvement of the health system response. It consisted of 57 participants across 6 participant groups, and they were recruited in various manners. We involved health policymakers, primary care physicians, psychiatrists, mental health officers, people with severe and enduring mental illnesses, and their caregivers. So as you notice, the participant group is very broad, and this is because we wanted to have a comprehensive view of the issue of people at different levels of the system being able to pinpoint what exactly are some of the advantages of the system, what are the disadvantages, and how do we address these issues. We especially wanted to focus on the people with serious mental illnesses. As you notice, they have the largest participant group in the study. And that's because often their voices are not included in things that are about them or as a source of information, relevant knowledge that can actually help develop systems. And the WHO has asked us to do more to include this group in research as experts of their own health. Now, sorry, I think I went ahead too fast. Now, this will be our focus slide for now. So just to give you some context, this is what we found coming out of the study, but just to give you some context, these are the strategies that the participants felt were needed to improve the health system response. But for you to understand this, I'll tell you the background. So we found that across all participants groups, they recognized that the free public health system was the #1 enabler of healthcare access. People were very grateful and recognized that based on the socioeconomic status of most people who have severe mental illnesses, the ability to go to a community-based health center that has co-located services was a huge advantage for them to get any level of care. So they were very thankful and recognized this as a valuable part of the public health system structure. However, despite this strength, they noticed several barriers and gaps that existed within the health system that limited their ability to access care. One of the main things was stigma and discrimination. And they recognized that stigma and discrimination existed at all levels of the society and even within the health system response to them. They also noted gaps in policy and guidelines, and we're going to talk about each of them in relation to this diagram. So the #1 thing that was needed based on stakeholder feedback is a paradigm shift in mental health. And this paradigm shift means recognizing that mental health needs to be addressed from a holistic standpoint and using that approach to care to improve the outcomes for people with serious mental illnesses, again, who are more prone to develop other non-communicable diseases. So some of the key recommendations made was, one, to make mental health sector priority. Now, let me be clear, this data was collected in 2020, so we are going to talk about what has been done since then. Secondly, reducing stigma and discrimination. Now, as I said, they said stigma and discrimination exists throughout the health service. They recognize that this is particularly potent within hospital settings where there are a number of barriers for people with mental illnesses to get care. They said that once they present, sometimes the administrative staff, sometimes the security guards act as gatekeepers and prohibit them from being able to see the doctor. They're recommended to mental health services when they're coming for a physical health concern. And they will not present because they feel sometimes they're embarrassed or made to feel ashamed. And people loudly declare that they are mentally ill. And so that keeps them away from accessing healthcare. So some of the key recommendations for this was, one, there needs to be improved training of health system staff. And yes, this extends to physicians and clinicians, but even extending to administrative staff and security personnel, because again, they act as gatekeepers. Another one was to increase mental health promotional messages. So as stigma and discrimination is widespread in the society, there's a need for greater emphasis on promoting mental health, especially as this may help to address some of the social support gaps for these people, which was found to be very great in this study, that they don't have much social support. The next one was about filling gaps in policies and practices. So one of the things that came up, especially among the clinician groups, was that it was unclear whose responsibility physical health really was for people with mental illnesses. So, for example, most psychiatrists didn't see physical health as a part of something they're responsible for, even though they recognize that international best practices require that they screen for physical health conditions. Numerous barriers were noted as causing this gap, but they said there was a lack of a clear policy guideline for this population about what are the co-management requirements between a primary care physician and a psychiatrist to manage the holistic care of these patients. Another key area was about improving health system infrastructure. Mainly participants focused on the lack of a computerized system, issues with the facilities being inadequate to properly conduct screening within the community health system service. They talked about sometimes mental health not having a designated room, not having enough space to facilitate patients, which made it hard to conduct any sort of physical health monitoring. Another issue, of course, was related to workforce problems. Of course, we know that there's a limited number of specialized people with mental health credentials, and that was seen as a problem. But several solutions were suggested. One is that task shifting and sharing, where we redefine the roles and responsibilities of different members of the team. It was suggested that community health aides can do more, finding creative strategies to make sure that more can be done to help meet some of the needs of this patient population. There's also about encouraging psychiatric study. Some of the psychiatrists noted that even studying psychiatry was a stigmatized area because psychiatry was not recognized as a legitimate segment of medical professional, not as recognized or prestigious as other areas of study. And so there needed to be more incentives to encourage doctors to want to pursue psychiatry and to recognize it as something valuable to our society. And the third thing, this came up across all groups, was the need to invest in multidisciplinary teams. All groups recognize that the current health system response to mental health, especially as it relates to people with serious mental illness and chronic illness, was limited because of the biomedical approach that focused heavily on prescription medication. The number one barrier to people with mental illnesses accessing care was poverty. As that lady pointed out earlier, sorry, I didn't catch your name, medication adherence is affected because they can't afford it. They can't afford medication. They can't afford food. Some of them have unstable housing. The people with mental illnesses are especially vulnerable group because they're so marginalized and stigmatized. And so when we talk about respond to social need, actually investing in multidisciplinary teams is a part of that. More social workers, more psychologists, more occupational therapists, people who can address not just the medication part of it, but who can tap into skills training and development to help improve the quality of their life so they can better manage their health. And so that leads to the part about respond to social needs. So the major gap recognized in the system, again, across all groups, was the lack of focus on social factors as a key contributor to the challenges that people in this population face. And that as a health system, there's a need to give greater focus on how do we respond to social need within the health service. So some persons suggested that a multidisciplinary team approach, multi-sectorial approach was needed, and I'll talk about that a little bit more. So these were the key things that came out in the study. Now, what are some of the key points that we need to talk about? So since the time of this study, we know that some actions have been taken. The primary healthcare reform for Jamaica report that was recently released indicates that mental health has now become a priority issue. I noticed that COVID-19 must have contributed to that in some way. We saw recently that the Medical Council of Jamaica has announced a mandatory training for primary care physicians to upskill, which is greatly needed and a move in the right direction. And greater sensitization has been happening about mental health in the public sphere. So these are advances that the systems has made. Now, what are some of the things that are needed further? Further actions that need to be taken based on the recommendation is moving mental health from just being related to a health issue to one of a social issue. Now, Hutchinson 2009 already outlined a great deal why it's important that non-communicable diseases are seen as a multi-sectorial issue, because it's necessary for economic viability that it's addressed as a civic issue. So people will stop seeing it as their problem issue and recognize that it's something of national interest, that we need to focus on NCDs more and get different sections of the society involved in that response. There's also greater need for shifting from the biomedical approach. In the World Health Report 2022, the WHO has put forward the need for person-centered, human rights-based, recovery-oriented approaches. Now, recovery-oriented approaches focus on teaching people with mental illnesses, upskilling them to be able to do more self-management, equipping and empowering them with the skills needed so that they can better manage their lives. It's not so much about medicating, but it's now about empowerment. And so taking steps towards figuring out how can we pilot and consider this within our local context. Again, invest.
Can you wrap up, please?
Invest in. Time is up?
Yes, you need to wrap up. Yes.
Yeah, I'm coming. This is the last slide. And investing in multidisciplinary teams and in implementing structured piloting of task shifting and sharing, and of course, improving training within the health system staff. Sorry about the time. Thank you very much.
Thank you, Dr. White-Smith. Of course, her presentation is very dear to me. It's up my street. So, I could sit here a whole evening and listen to her. But to be fair to you, we must move on. So we're going to ask Nurse Shanae Linton to do her presentation. Please make her welcome.
Thank you. Good afternoon, everyone. I'll be presenting this afternoon on patient satisfaction and the factors influencing satisfaction in the accident and emergency departments of Type A hospitals in Jamaica. So just some background. The Institute of Medicine defines quality care as the degree to which health service for individuals and populations increase the likelihood for desired health outcomes and are consistent with current professional knowledge. It also encompasses how care meets the needs or exceeds the needs of patients and their expectations. And there are the Agency of Healthcare Research and Quality put forward some domains that are used to measure quality in healthcare. One such is non-maleficence, which is do no harm, patient-centered focus, and customer service, evidence-based treatment, timely care, and equity in how service is provided. So we want to establish that patient satisfaction is an important aspect and a very strong indicator of how quality service is delivered. And we use patient satisfaction to refer to how patients evaluate the quality of care that they receive. Patient satisfaction offers information on the provider's success at meeting the expectations that are most important to the client, and it is the key determinant of whether or not these patients will continue to have good and positive future health-seeking behaviors. When we looked at studies done previously, we highlighted that there are some, Bursch et al. In 1993 determined that what matters most when considering emergency room patient satisfaction is the relevance of how care was delivered. And they concluded that while time was significant, the most crucial factor was how patients felt that they were tended to. They highlighted factors such as thoughtfulness of their providers, the knowledge base and the caring attitudes of staff, and whether or not their complaints were handled with urgency. Roberts in 2001 found that other factors affected satisfaction, such as gender, place of living, educational level, age, income, marital status, and so on. The studies in Jamaica that have been done to measure patient satisfaction so far have primarily been centered around nursing care. And Buchanan et al. In 2015 explored patient satisfaction in nursing care in emergency departments of an urban teaching hospital and found that the mean satisfaction score was 32.6 out of a possible 42. So why study patient satisfaction? This satisfaction amongst our citizens is always in the media, and it is said to deter citizens from readily seeking health care services within our institutions. Members of society continue to express their opinions of poor quality services that are being offered and the substandard customer service that is being offered in our public institutions. And we found that there was no study found in Jamaica to actually focus on the overall experience in the emergency rooms in Jamaica. So we set out to examine the factors that influence patient satisfaction, and we believe that this will be most helpful in how we go forward in treating our patients. Described the aim before. Our objectives were to look if there were any correlation between socio-demographic characteristics and patient satisfaction, to determine how patients perceived the wait time that they had to receive service. Also, we looked at patient satisfaction in terms of the information they received, the responsiveness of personnel to their needs, the empathy shown to them. So our methods. We embarked on a cross-sectional study, and we used a quantitative approach to collect data using questionnaires The population was all patients seeking medical care within the accident and emergency departments of type A hospitals in Jamaica. And we know that the type A hospitals are Kingston Public Hospital, Cornwall Regional, and the University Hospital of the West Indies. The persons that were included were persons that were of age 18 years and older, and who could provide informed consent. Who were excluded, persons that were of ESI 1 or 2, that means that they were determined as unstable or emergent, or their situation was emergent or needing urgent care. Persons that were unable to provide informed consent, visitors and not patients were excluded, and persons that were of impaired cognitive status. We also excluded persons that were admitted to the hospital, meaning that even though they went through A&E, after being seen and treated, they were admitted. Those persons were also excluded from the study, as the tool that we were using was specific for emergency department visits, as having been seen and discharged from the A&E department. So, using information based on the amount of persons that were seen in the emergency rooms for the type A hospitals, we came upon and we determined the sample size, which gave us approximately 267 patients, the majority being from Kingston Public Hospital, 92 from Cornwall Regional, and 60 from University Hospital of the West Indies. We chose days at random to visit the hospitals, and weekdays and weekends were included. Patients were approached randomly and at various stages during their visit, and those who were refused, another patient was selected. During recruitment, informed consent was obtained. We used a 38-item questionnaire, interviewer-administered questionnaire, to collect our data. And the questionnaire consisted of questions regarding socio-demographic characteristics, wait times, patient satisfaction with information received from healthcare personnel, responsiveness of personnel to their needs, the empathy shown, and the care provided. We used SPSS version 20 to analyze the data, and we used descriptive as well as inferential statistics to determine the values or to analyze what was the data. A significance level of 0.05% was used, and the EDCAMS questionnaire was broken down into composites that we would use to measure or determine patient satisfaction. I'll break down the composites later. The results from our study: the majority of patients that participated were female, 55%. The mean age of the respondents was 43.52 years, and the age distribution revealed that 24% were belonging to the 18 to 28 age group, and 19.9% belonged to the 29 to 38 age group, as well as the 49 to 58 age group. The educational level that was most prevalent was secondary education, with 66.7 persons reporting that they were from that level of education. 69.1 were employed, 30.9 were unemployed, and 35% disclosed that their income ranged between $15,000 to $19,000 weekly. And we have a breakdown of the socio-demographic characteristics. With regard to the composites that the questionnaire had broken down the measurement into, we saw where the mean score for these composites range from between the 60s and the 70s. These scores were average out of 100. So getting timely care, which measure the initial patient interaction from they arrived at the emergency department to when they received care within 30 minutes of their arrival. The mean score was 66 out of 100. Communication with doctors encompassing courtesy, respect, along with effective communication, the mean score was 76. Medication-related communication was 63. and communication about follow-up care was 63 as well. Majority of patients, 52.1%, reported that they waited from registration to completion of care over 6 hours. This was followed by 22% stating that they 22% stating that they waited 4 to 6 hours to receive care, and the lowest number of respondents, 6%, stating that they spent less than 1 hour in the emergency department. 54.7% were satisfied with the time that they spent, even though it was over 6 hours, and 45.3% stated that they were not satisfied with the amount of time they spent. We noted that there was a direct association between the hospitals and the amount of time spent. The majority of patients' responses from Cornwall Regional Hospital stated that 88% of them waited more than 6 hours. At University Hospital, it was also greater than 6 hours. And at KPH, 33.9% stated that their wait time was between 4 to 6 hours. The doctors and nurses' communication, majority of patients reported that they were treated with courtesy and respect by the nurses. 53.2% reported that the nurses always listened carefully. 58% said that the doctors always listened carefully. And majority of the patients, 52.4%, reported that the nurse explained things so that they could understand. About medications, 83% of participants stated that doctors and nurses asked questions about the medications that they were taking from home. The majority of them, 63%, stated that they did receive medication in the emergency room. However, 75% reported that side effects were not explained to them. The majority of patients reported that the medications that they were given to take home were not explained to, they were given medications to take home, but 95% said that they knew and it was explained to them what the medication was for. About follow-up, 53% stated that they were not provided with information about symptoms or health problems to watch out for at home. And 22% of respondents indicated that they did not receive information about follow-up care. The overall experience in the emergency rooms were rated from 0 to 100, with 21.7% awarding the emergency rooms a 10 out of 10. 21% of participants rated their experience at 9, and the lowest possible score that could be achieved, one respondent gave a 1 out of 10. And we saw that there was no relation between the hospitals, the different hospitals, and the different scorings that were done. 78% of individuals said that they would definitely recommend the services of our Type A hospitals emergency room, and for Cornwall Regional Hospitals, 78% would recommend, as well as 76% from KPH said that they would recommend. So, even although we would have presented previously that persons in media would have spoken about the dissatisfaction of our citizens with the services that we provide, our study has proven contrary, as 78% overall satisfaction among participants was determined. And we know that in analysis of getting timely care, there was a significant difference between the mean scores between males and females, which suggests that there was some association with gender and their perceptions of receiving timely care. There was no statistical significance between patient satisfaction among the responses, as I said, from each hospital. The strengths, the study of this kind is first in Jamaica, and we think that we could do other qualitative analysis to determine whether or not the results are actually significant in terms of, are we just used to this level of service, or can we be exposed to other things in the future? And it can also help to develop how we provide care. Limitations, we only focused on type A hospitals in this study, so we could broaden the horizon, as well as there was a predominant high level of education, with majority of persons having high school or higher level of education participating. In conclusion, patients who visit the accident and emergency departments of type A hospitals in Jamaica gave a general high rating for their overall experience, and there is an appreciation for the current provision of services and the information given regarding follow-up and medications. Patients' communication with doctors and nurses is considered to be effective, and there is a significant dissatisfaction with wait times spent in these departments, mostly in excess of 6 hours. Here are our authors, and thank you.
Thank you, Ms. Jenny Linton. Very important presentation, because so many times we just focus on the numbers going through, but we need to know how patients are perceiving what we are providing. And it's good to hear that overall satisfaction is quite great. You know, we are doing some things right. Any questions?
Much for your excellent presentations. For the Mrs. Smith online.
White on Smith, yes.
Yes, Mrs. Smith online.
Still online?
Yes, she's there.
I am here.
Yes, she's here.
Question for you.
I can see, so she can see me. So the question I have there, where the doctors for mental health are being regarded, I use the word as maybe looked down on, as not as qualified as the other physician, or rather maybe they are insane because they're going to take care of mad people. So what do you think? Because you see the brain, we can't see our brain. We can see our eyes, we can see the skin, we can see everywhere else. And then if there's any little blemish, you want to rub it off, you want to take care of it. But the brain, you can see. So do you think if we have a way of ensuring that the brain is assessed, you know, you have a way of looking at your brains and know what is happening to you, you might be able to appreciate those who are indeed taking care of our mental health. Do you think that will be a plus?
Thank you for your question. I think, well, there are other studies in Jamaica that has shown that mental health literacy is very low. I don't know. Okay, yeah. That mental health literacy is generally low, and that's not only among the general population, but even among professionals. And that, I think, contributes a lot to the perception of psychiatrists. One psychiatrist described psychiatry as the ugly stepsister, which I thought was such an interesting way to describe it. That they're given the rooms at the back of the health center, and they're seen, you know. So she was just trying to show that throughout there is this sense of, if you're doing this, you know, you're less than. And we have to do a lot more to educate people about the seriousness of mental illness. As a global problem, it continues to grow, and it's becoming more formidable because we're reluctant to address and recognize the need to see this as a central part of care and health care. So yeah, we definitely need to put more focus in this area.
Okay, so it will be better if I see my brain just like I see my eyes and my skin. Good. Now the next question for the last presenter. Can you just tell me what is type A hospital?
What are type A hospitals?
Yes, like I keep hearing that. I hear type A, B, C. Yes. Maybe there's somebody who don't understand, like me.
There are different classification of hospitals in Jamaica. Type A facilities are the ones that offer the majority of services in terms of surgical and referral in ICU and other severe health services for Jamaica. So Cornwall Regional, that is able to provide service to all the specialties, including surgery, ICU, having outpatient clinics, and so on. They're able to operate as type A facilities.
Okay, so is there a case where government can deliberately improve a type C to a type A?
Is there a case where?
Yeah, can it be done because you want to ensure that person? Because I know that persons are referred from probably somewhere to UWI or to KPH.
Persons are referred. You're asking if they're referred or we can upgrade?
No. Can we take a type C to a type A? If you want to give a better healthcare, instead of somebody traveling all the way from type C to come to a type A because of the level of care that is being offered.
I understand. So the services at a type C hospital would have to be upgraded as well. So we would have to ensure that the facilities are upgraded to meet the needs of the patients, including not only infrastructure, but the medical knowledge and the medical services of the personnel there in order for it to be upgraded. Because of monetary constraints or whatever the reason is within Jamaica, we have specific hospitals at this time that provide that service.
Okay, thank you. The last question. Now, the result you got is different from what we were expecting.
Truly.
All right. Now, can it be reproducible?
Can it be reproducible? I think so, because even while we were there, even on a qualitative basis, speaking with the patients there, you would understand from them that they're willing to wait. They're willing to be there, and they have made up their mind that once they're coming, one thing they're guaranteed of is that they will receive an answer for the question that they have. So irrespective of the fact that they complain about the wait times or might say sometimes that they are unfairly treated, what they leave with at the end of the day is that the answer that they went for, the situation that they went for, was answered and resolved.
Okay, so
I do think it is repeatable.
It is because I was just going to say to you, probably it was the group of people you met on those particular days.
It's not because I'm nice.
Okay, so or rather because I've been hearing a lot from different persons. So I will be glad if we can repeat it. Since it's the first of its kind, so I'm going to encourage researchers in the room and those online
as well.
And go check how you can do more and check different groups of people, and let's find out if we can maintain these very same
We
results.
can still improve, because they're waiting 6 hours and more, so we can still improve.
Definitely.
But yes,
all right. Thank you.
I think so.
Yeah, just good afternoon. Just following on that question Dr. Alonge asked, with regards to the results that you got, were you surprised that there was no difference between all three hospitals? Because
were we surprised that there was no difference in terms of the satisfaction levels?
Yeah, the satisfaction levels.
Not entirely. Why? Because we recognize that there is a certain cohort of patients that go to UE versus KPH, and everyone knows what they're looking for at that particular institution. So irrespective of the fact that we went to the 3 locations, persons have now become acclimatized as to what to expect, and we were not surprised that the results were not different. We did anticipate some level of skewness at KPH. However, then I must say, we were pleasantly surprised there because nobody was complaining about their level of satisfaction there. Persons reported that they were indeed satisfied.
Okay, thank you.
Good afternoon. I am a visitor, but I'm just curious. What type would you call Spanish Town Hospital?
Is it, no, it's not B? B.
Oh, B, okay.
Thank you.
Dr. Coburn? Oh, sorry. Yes, Dr. Coburn, we're going to read some comments from the chat, and persons are saying, excellent presentation, ladies, and quite a few persons have indicated that these presentations were great. We have learned a lot, and you guys are doing very well. So excellent presentations from this group of ladies. Oh, we do have one more question.
Just before Muzaz asks this question, I need to make a comment because of the whole, especially on Ms. Whiteon-Smith's presentation, because it really speaks to what we are trying to do in the Ministry of Health in trying to see how we can make sure not only that our mental health patients, that their curative conditions like high blood pressure, diabetes is taken care of, but also to recognize that sometimes persons have non-communicable diseases in the curative clinics, sometimes they are depressed, so they have anxiety problem, and that affects adherence. So we want to not only increase the mental health professionals, make sure they look out for the non-communicable disease, but also that the non-communicable disease physicians also look out for the mental health issues which can complicate the outcome of their treatment of patients who have other non-communicable disease. Muzazi, your question or comment?
Yes, just a quick comment to point out that interestingly, a 6-hour waiting time for non-ambulant patients at accident and emergency is actually within the global time range. It's not too far, which is what I found interesting. And of course, as our minister likes to say, patients come to the clinics not to necessarily get well, but to feel well, which is a difference.
Yes, yes.
Thank you.
Yes, thank you, Muzazi, for your comments. And then my last point is the importance of how we relate to our patients. And that's where an important part of our, what we call mental health gap action program is really essential care of practice, which we think all physicians, all nurses should display when they are interacting with their patients. So have empathic communication, caring attitude towards the patient, because you may be very knowledgeable, but if you don't have attitude towards the patient, then therapeutic alliance will not be there and the outcome will be negative. So thank you all, presenters, for your well presentation. Please give a round of applause for their excellent presentations.
And once again, we want to recognize our moderator as well, Dr. Goldburn, and we want to thank him for ably taking us through this session. So thank you once again, Dr. Goldburn, and thank you to our excellent presenters. So I'll just invite you all to stand down and take your seats. And we won't take a break. I'll just go into the closing remarks. We really have to give thanks, even though we have not reached the end of the 3-day sessions. But in reflecting, we have come to the end of 2 days of 21 oral presentations. Today we had a special presentation from our permanent secretary, followed by presentations on the applications of technology in public health. We also had our scientific presentations, which covered laboratory studies, the impact of communicable diseases, reproductive studies, and social support and mental health. As a reminder regarding a few housekeeping matters, we remind you to explore our virtual platform. You have one more day, so one more day to get yourself on the leaderboard for your prizes and surprises. Please join us tomorrow, where we will have panel discussions and special presentations on a number of areas. These include reproductive health and pregnancy in older women, reproductive health and environmental pollutants, sessions on communication for researchers, healthy eating and you, backyard gardening, and reasoning on the wellness bench. Our final session after lunch tomorrow will be on telemedicine and ethics. So you will see that we still have a feast in store. We will also be showcasing our poster and oral presentation award winners. So we ask you to join us in the afternoon tomorrow. We continue to give thanks for an excellent day, and we wish you a good afternoon.